Good afternoon, NAACP leaders, members, community partners, panelists, and attendees. Welcome to the State of Maternal Health, Black maternal health in the state of Arkansas panel discussion. I am Wanquita Nettles, and I serve as the Arkansas State Conference Health Committee Chair. And I am elated to introduce to you all our panelists as well as our moderator for this afternoon. I would like to start out by introducing Dr. William Greenfield, and his bio reads, Dr. William Greenfield, MD, MBA, FACOG, is a professor of obstetrics and gynecology at the University of Arkansas for Medical Sciences, UAMS, and serves as the medical director for family health at the Arkansas Department of Health. Dr. Greenfield earned his Bachelor of Science in Pharmacy from Auburn University and subsequently attained his Doctor of Medicine from Meharry Medical College. He completed his residency in obstetrics and gynecology at UAMS, where he has been an esteemed faculty member since 2004. Throughout his career, Dr. Greenfield has made significant contributions to healthcare, accountability, accessibility, and innovation. Notably, he spearheaded the implementation of the telecolposcopy programs for the Arkansas Department of Health, expanding healthcare access to underserved communities. His research endeavors in women's health have been particularly impactful, focusing on a therapeutic vaccine for treating patients with cervical dysplasia. In addition to his research and clinical responsibilities, Dr. Greenfield has been instrumental in advancing maternal health care in Arkansas. He played a pivotal role in establishing Arkansas's Maternal Mortality Review Committee and currently serves as medical director for the Arkansas Perinatal Quality Collaborative, committed to excellence in healthcare. Dr. Greenfield is respected for his dedicated service to clinical practice, education, advocacy, and innovation. Our next panelist is Ms. Kwaizi Galladay. Please pardon the mispronunciation. Ms. Galladay is a native of Arkansas, and she is the owner and founder of Kwaizi of Willowing Aya Doula Services, and she strives to make the world a more equitable space for all. She is dedicated to assisting her community with navigating resources and becoming their best selves. As a doula, she operates as a guide for her clients and their families throughout the pregnancy, birth, and postpartum stages of childbirth. She is doing what she can to reduce maternal and infant mortality rates in the state of Arkansas and women of African American descent by being their guide when strength and vulnerability collide. Our next panelist is Mrs. Nicole Fletcher. She is a native of San Diego, California. She is the wife and mother of 3 adult children. Nicole was an Army officer's wife for 7 years until they moved to Conway, Arkansas in 2007, where they still reside. While the move to Arkansas was intended to be a short 2 years, there was a mission beyond what she could have even imagined. Nicole co-founded the 501c3 nonprofit City of Hope Outreach alongside her husband and their 3 children in the fall of 2007. She then trained to become a certified doula in 2010 after a year-long training. In 2011, she became a childbirth educator, and in 2012, she became a doula trainer and mentor. Nicole has trained 45 doulas over the course of 12 years. In 2017, she became a certified lactation counselor through the Healthy Children Project. She then added a health coaching certification through Dr. Shear's Wellness Institute in 2019. Ujima Maternity Network Incorporated was formed on Ujima Day, December 28, 2019, and became a 501c3 nonprofit in 2020. Nicole is the visionary, co-founder, and executive director. Nicole is passionate about improving maternal health in Arkansas and has actively utilized all of these certifications and skills to better serve the community of birthing women. Last and certainly not least, our last panelist is Miss Eris Duhart Lewis. Mrs. Eris Duhart Lewis is a native of Little Rock, Arkansas. She is a mother of 2 who is an advocate for improving the birth environment for women, specifically in the state of Arkansas. Eris has a bachelor's of science in biology and a master's of science in clinical research organization and management. Her family has a long history of contributing to birth spaces, as her grandmother was a midwife and her father was an OB-GYN. Therefore, it was natural for her to answer the call to become a certified birth doula. It is her goal to improve the maternal healthcare crisis by assisting women to have healthy and safe birth experiences. I want to commend all of our panelists for being here. Thank you. Now to introduce our moderator for today. Mrs. Donna Rayford Graves is a graduate of Little Rock Central High and Baylor University. She has served in the nonprofit sector for 20 years, over 20 years, and currently works as a development officer for Arkansas Children's Hospital. She is a subscribing lifetime member of the Little Rock NAACP branch 6019, where she serves as interim secretary. Donna is also a member of a number of local civic organizations and was recently elected as second vice chair of the Pulaski County Democrats. Congratulations, Donna. Donna is the wife of Mr. Triney Graves, and I hope I said that correctly, mother of Jessica, mother-in-law to Corey, bonus mom to Katrina, and a proud gram to 8-month-old Olivia. Miss Donna, you are free to begin this discussion. I yield the floor. Thank you.
Much, guys. It is so great to be here, and I'm just going to be myself, if that's okay. I'm not going to be too prim and proper. I'm just going to be Donna. I wanted to kind of ground us with a couple of things, and so it's great to hear that Dr. Greenfield is on the call, because we know that in 2023 we got that Maternal Mortality Review Committee report, and I, along with so many people, were shocked and saddened to see where we stood. And so I just kind of want to hit some basic statistics for us to kind of keep this in mind. That Black non-Hispanic women in Arkansas are 2.3 times more likely to die from pregnancy-associated causes than white non-Hispanic women, and that Black women are 1.8 times more likely to die from pregnancy-related causes. And Black women in Arkansas are also 3 times more likely to die from pregnancy-related causes than white women, if I didn't already say that. In the US, Black women are 3 times more likely to die from a pregnancy-related cause, and that's from the CDC. So as we get started here, I also wanted to read just a portion of a statement from Dr. Jamila K. Taylor, who is the president and CEO of the Institute for Women's Policy Research. And she says that this shameful truth is that ongoing structural racism plays a central role in the deaths of Black women. Biases within the medical profession still shape the care that Black women receive or don't receive during pregnancy, often with tragic consequences. This is true for all Black women, regardless of their income levels or where they come from. So that's kind of where we are. This is definitely a crisis, I think, and I think the folks on this panel would agree. So what I was hoping by starting with that is to have, maybe we could start with Dr. Greenfield. If you could, the question that comes up is why, but if you could kind of give us an overview of what this statistic means and from your point of view, what can be done, I think would be great.
So unfortunately, our nation and Arkansas particularly have the dubious distinction of having the highest maternal mortality rates in developed world, and Arkansas has among the highest rates within our country. So, which puts us on very, very poor footing. And then when you get down into certain counties and certain communities, Black community in particular, our numbers are much higher as well. So there are definitely some problems that we face there. And this is likely due to a number of factors. We see a number of things actually contribute to this, and to some of which you've already mentioned. And then there are other factors as well. And it's not really just a one factor issue in terms of leading us to this issue. Issues in terms of generally poor health can be a contributing factor, limited access to care, limited support through care. There seem to be correlations that are impacted in terms of how people actually come into pregnancy, ability to maintain access to care during pregnancy and even in the postpartum period. And so when I say that is to say that it's not one factor. There are a number of factors that likely are contributing to this. And when we look at the top causes of individual disease processes that are causing maternal death, for example, heart disease, cardiovascular disorders, hypertensive disorders are among the top causes. And I'd like to just introduce another point into this, is that while we talk about maternal mortality, and this is incredibly tragic and provocative, not to be lost in this conversation is what I would call maternal morbidity. And those are the situations where mom actually, she did not die, thank goodness, but they may have had a complicated birth experience. So the mom goes home, but she may not go home exactly the same as she was when she went in. So I don't think that should be lost in this conversation.
Thank you, Dr. Greenfield. Thank you for adding that piece. Let's see here. Let me get all my names correct. Kowesi. Did I say that correct?
It's quite easy.
Quite easy. That's not hard. I'm sorry.
Yes.
Quite easy. I wanted to go to you and then to Dr. Fletcher to just talk about, for one, I would be interested to know what made you all go into the role of doulas and where you think how doulas can play a role and help bring down these statistics.
Okay. So yes, I'm quite easy, and what led me to become a doula is I was pregnant myself. So I was pregnant with my second child, and I knew that I wanted my second birth experience to be different than my first. My first birth experience, I was a teen mom, and therefore, even though I had this idea of how I wanted it to go, I don't think I was really taken seriously because I was a teenage mom by my medical staff. where they kind of diminished my thoughts when I said, like, I don't want to use a lot of pain medication. I want things to go as my body says to go, even at 14, 15 years old. I don't think they really, paid much attention to me and what I was saying. And so my second time around, I was like, I want more information. I want to know how to prepare myself. And I went online to search how to better prepare for birth. And the word doula popped up. Before that time, I had not heard of a doula before 2018. When I got to searching, like, are there any doulas in Arkansas? And then I went down even further and said, are there any Black doulas in Arkansas? And that's when I came across Nicole Fletcher, and she was my doula for some time as I prepared to give birth to my daughter. And afterwards, I said, I want to do this. I want to be a part of this work. I want to educate more women on how to give birth in the way they see fit. And I actually was trained and mentored under Nicole Fletcher, thankfully. So I think that doulas and our role with all of this is really being a steward of education, a place where honest conversations can take place, where we are in the rooms. So there's other people who have prior knowledge, people who have information, people who can be like this liaison and middle person between the client and the medical staff, so that both needs are being met, so that understanding can be reached. I think that's a big role for us as doulas.
Thank you for that. Well, I can say personally for me, you're right. 29 years ago, when I had Jessica, I wanted a doula. I knew about doulas thanks to my grandmother. And I could not find one in this whole state or even this region at the time. So it was something that I really wanted. I did not get to have it. But when my granddaughter was born 8 months ago, she was able to have a doula. My daughter was. So that was very helpful. Ms. Fletcher, with you, was there something about an experience you had had, or what led you to try to look at the ways in which doulas can help in this area?
Yeah, thank you for this opportunity to be here. And I just want to provide a point of clarification. I think it was mentioned, Dr. Fletcher. That's my husband, it's not me. So I just wanted to clarify for the room. I'm not a doctor, not a PhD or an MD. So just want to be clear so nobody feels any type of way. So what led me down this road is I actually had 3 unmedicated births myself. I actually had no problem. I had beautiful birth experiences. Really amazing birth experiences. I delivered in California, my first. My second, I actually delivered here in Arkansas at UAMS. And then my third, I delivered in Kentucky on the military base. So my family's very interesting. I'm from California. My family's from Arkansas. My husband's family is from Kentucky. So each one of my children were born in a state that's related to our family. So I think that's really beautiful and fun for us. But when it comes to like the role and why I'm in this, it's really, I started out because it was fun. I mean, it was just kind of cool to think about, oh, let's help a woman have a baby. Yeah, let's come alongside her and let's link arms and say, girl, you got this, you can do it. And so that's where it began, was just, this was cool. And then over time, I started to realize, my eyes became open to the actual crisis, to the fact that there is an issue and that women weren't being treated equally across the board, and that some experiences were actually not great at all. And like Dr. Greenfield mentioned, not only the mortality, but the morbidities. And those are experiences where, again, women walk away living, but their experience, they're not the same woman that walked into the hospital, right? And so that impacts the whole family structure and the whole family dynamic. And when we talk about Black maternal health care, my thing is, who better to speak to Black people about maternal health care and the support than a Black woman, right? Because this impacts not only me, it impacts my daughters. It impacts the woman that my son may choose. You get what I'm saying? So it has the further impact and a further reach. So there's a responsibility. If not me, then who? If not now, then when? Was really kind of became the question, is like, let's get involved and let's start changing the trajectory. of health, and it's twofold. It's the healthcare system, but it's also the community. It's also that birthing mother. It's also the support system that's around her, and getting educated and taking responsibility for their own experiences, their health. Dr. Greenfield mentioned some pre-existing conditions, taking charge of that, and then looking at the resource. Kwaisi mentioned she wanted a different experience, so she sought out doula support. And I just want to clarify for the room, there is a difference between a midwife and a doula. And often there's a lot of confusion and a mixture of the two. So there are different types of midwives. There are CNMs, which are certified nurse midwives. They typically work in the hospital alongside an OB. It's kind of their typical niche. And then there's the CPM, which is the certified professional midwife, or as noted in Arkansas, lay licensed midwives who typically work outside of the hospital. And they're responsible for the primary care of the woman, seeing her prenatally, and then their birth typically happens at home. And that constitutes a really small number of the population. But when we look at our roots here in Arkansas, our roots are very founded in birth outside of the hospital. And so it's really important to consider that and understand that. But a doula is not a midwife. And I ran into an older woman, an older Black woman, several months back, and she was like, "Oh, you guys just come up with all these new terms." And so she was thinking that a doula was a midwife and just it's a new term. And I was like, "Ooh, we've got some education to kind of step out." So a doula provides physical, emotional, informational support, and advocacy. She is a non-medical person, so she comes alongside and supports during the pregnancy or prenatal period, during the actual labor, and even in the postpartum. But again, her role is not medical. So information, education, like physical support, emotional support, and then that advocacy piece. So I'm gonna stop because I'm a talker. So I'm gonna just pause right there.
All right. Well, thank you so much. And thank you for making that point. I apologize. Sometimes I tend to think everybody knows all the same things. So thank you
Yeah.
very much for pointing that out. That is a big difference. I want to go ahead and let Aries kind of speak upon what brought her to the work that she does before we go on to some more specific questions.
Yes, thank you. So I am a new doula in these streets, actually. I was certified through the Ujima Maternity Network. And what really called me to start this service is because, one, I didn't have a traumatic or I guess unpleasant birth experience. However, I did have, I would say, an uneducated birth experience. There are things where I said I wanted to do, but I didn't understand what needed to be done. For example, I said I wanted to have a natural birth. I said that I did not want to have an epidural, but then I agreed to be induced. I agreed to have Pitocin. I didn't let my body follow its natural course. I agreed to have certain interventions that I didn't need, and I put myself at certain risks that I didn't have to be put because I was uneducated about that. And I am a college educated woman, but I wasn't educated about the birth space and what is needed in that space. And so I didn't have anyone there to really guide me through that. So I had my doctors, my dad is a physician. So I had people there, but I didn't have anyone to speak to. Okay, Eris, you're saying you want these specific things. However, what you're doing is contradicting what you want. So for example, I said I didn't want an epidural, but then I got induced and I ended up having to get an epidural because my birth was stalled. The pain was great, and so all those things could have been prevented had I been educated or have someone to at least make me stop and think. Even from when I checked into the hospital and all of the paperwork that I filled out, I just signed yes to everything. I didn't think about what I was agreeing to. I didn't think about what my options were. I just went with what my physician said to do. And that was where a doula could have stepped in to really make sure that I understood what I was signing up for. And so I also am a mother of two, and I have people within my family and my friends that come to me and they ask me questions. And I felt like I needed to go and seek out more education, because we do have people within our community where they will rely on certain family members that give them uneducated advice. And so making sure that I can truly give evidence-based advice, still leaving autonomy for the mother to make her own decisions, but understanding fully what those decisions mean. So that's why I answered that call.
Thank you so much. You made some really good points. So I wanted to go back to the area, Dr. Greenfield, you were talking about some of the reasons for the fact that Black mothers are so much more likely to deal with higher rates of mortality and morbidity. You were talking about like around heart disease. I guess my question would be, what are some of the ways in which we need to look at the health of Black mothers before they're even expecting?
Well, I think one is establishing good care and establishing primary care. And some of these things are real sound, basic, but I really don't think they should be minimized. And number one, it gets to an issue of body autonomy and women having an opportunity to control their reproductive life, starting their families when they want to start their families. That I think is incredibly important. It's incredibly important to help them engage with their physicians. It's very important when it gets to matters of birth spacing, so that they have access to effective contraception when for example, when a mom has a child and she wants to have a second child. A host of these things are incredibly important. Another factor that sort of I didn't really allude to was that we see that women who are older, advanced age is an independent factor. So moms who are over the age of 35, that can be a factor as well, because there are going to be more medical conditions that may enter into a person's life as they age, and that can be a factor as well. But then there's generally an increased risk. Black women have a higher rates of preeclampsia, preterm births, a host of things as well. So it's really not just one factor. So one, becoming pregnant, entering into prenatal care, and then when they have effective, compassionate, empathic prenatal care, one of the cornerstones of that process will be trust. And will be trust with their provider. And I think this is where doula support really kind of comes in, because for the people who work in the birthing fields, this is something that we do every day, and if we are not careful, we can go through the motions. But for a patient, this may be a once in a lifetime experience, and if there is not an opportunity to slow down and to explain and to make sure that what is said is actually understood, then there are certainly lost opportunities. But the most frequent causes of pregnancy-related deaths, when we've looked at our region, if I were to say Arkansas, Oklahoma, Tennessee, Missouri, Kansas, Mississippi, Louisiana, for non-Hispanic Black women, the top causes over a 3-year window that was looked at a few years ago were cardiac conditions, cardiomyopathy, which is a specific heart disease, embolic and thrombotic events, and hypertensive disorders. So, but then other factors that are not in this number of mortality, increased risk of hemorrhage and bleeding, things like that can be among some of the leading causes of morbidity and mortality. So it really is not a single factor, but one of the greatest recommendations I can have is being as healthy as possible when someone enters into childbirth, seeking and establishing and continuing good prenatal care and postpartum care, and then all the things that we can do to provide support through the pregnancy and in the postpartum period. All of those things are going to be essential.
Thank you so much for going over that. One of the things that also, when you talk about prenatal care, so this is just for anyone, specifically to Arkansas, like I said, she said, I worked in nonprofit for many years across the health field primarily. And there's that whole issue that we have about advocating for ourselves and in terms of knowing the right things to ask a doctor. So when you talk about prenatal care, what are some things, or how can we help educate women in Arkansas about the importance of prenatal care? I just don't think that is something that a lot of people are aware of?
You know, in my opinion, there is a strong value in community, okay? And if relationships and the support network around that patient is in place, that can be something that is supported and reemphasized. And again, we mentioned the role of doulas in terms of being support. They may be a trusted member of this team, almost like a family member in certain circumstances. And then that may help to sort of facilitate this piece. Prenatal care, for some folks, it may seem like it's a very, and in many cases, it can be a very quick visit if everything is going well. But a first prenatal visit will be a very comprehensive review. It should be a very comprehensive review of a patient's history, a patient's family history, and it should be a process of outlining what the pregnancy process will be. I'll give you my spiel is. We're going to talk about our pregnancy in terms of weeks. We're not going to talk months because so many things are going to happen in certain weeks. We're going to see you at this interval. We're going to talk about the time in terms of when you're going to deliver it. We're going to talk about who do you anticipate being at your delivery. I've been doing this for about 25 years. I have been able to say with 100% certainty, I know typically there will be 2 people at that delivery with 100% certainty, mama and baby. Everybody else is going to try to be there, but I know mom and baby going to be there. So, and we began to sort of, and if we can, and it may be a process of introducing some levity into the conversation, but it's not to minimize it, but it's like, let's just have a really frank, a real conversation. And we're going to talk about what the expectations of these prenatal visits are, what we're looking for, what we're doing it. Everyone's going to get a urine sample. They're going to get a blood pressure check. They're going to get a review of the systems. They're going to get varying physical exams and varying labs. But it's important that we understand why we're doing this, because the things that can occur can be very subtle. They can be very subtle. And while most pregnancies, the vast majority of pregnancies are low-risk pregnancies, there are some that become high risk. And even the most mundane, the most routine, the most uneventful pregnancy could be an induction. It could turn to something where all of a sudden it's not routine anymore. And we want to have people informed. And that is part of the prenatal visit, to have these conversations so that people are empowered, people are prepared for this. And then this is where that trust piece comes in. And that trust can be elevated and built up, not only by the healthcare provider, by the physicians and the nurses or the midwives, but the doula and the role of family. All of this comes into play. And not to be lost in that conversation is the role of dad, the role of the father at that pregnancy and in that prenatal period. They should all be important in terms of helping to maintain the good, effective prenatal care, but also the postpartum care, because once the baby is there or the babies are there, this process, it just shifts to another phase. It doesn't just stop. It just goes to another phase. I will say a conversation that I will have is like, from the first prenatal visit, we are going to likely go from one period of worry to another period of worry. Let me make it out of the first trimester. Let me make it to viability. Let me make it to lung maturity. Let me make it through the delivery. And then after that, let me make it through this first year without an event. And if the people think it's just going to be like, oh, it's going to be no worries. No, there will be worries. And that's a normal phase, but that's where the support piece has to come in. And you can't get to that if you don't come to a prenatal visit.
Yes, thank you. Ms. Fletcher, were you going to say something?
I was going to jump in
yes.
when it came to that. I think there is a lot of undervaluing the prenatal appointments. And so it takes a lot of time. And, you know, Arkansas is about 60% a maternal health care desert. So that means about 60% of the state, women are having to travel at least an hour or maybe 2 hours in some instances to get to their prenatal visit. So if they are, let's say, a single mother, they're working a full-time job, they have other children, they're like, I am not gonna take off a day of work to travel up to this doctor's appointment and for me to see the doctor for 15 minutes, right? That's kind of some of the mindset that's out there. But what is missing is a lot of what Dr. Greenfield mentioned is all of those pregnancy exacerbates your health, if that makes sense. If there's an underlying condition, the strain and the stress of the pregnancy exposes that. And so a lot of women are like, I'm fine. I do great. I walk every day. Well, you don't really walk every day, but you know what I mean? And I eat McDonald's every other day instead of every single day. And so we have these poor diets and lack of a resource in our communities. And so those are some of the things that are impacting our health and our well-being. And then kind of like almost negating the value of getting that prenatal care. They're just going to check my blood pressure. They're just going to have me pee in a cup. And that's the mindset of the community. However, that information is very valuable to your health and your well-being. So I think just having that strong assessment of it's really important for you to attend these meetings or these appointments, even if you feel like they don't have the value that you understand. And that's okay if you don't fully understand it. There's still value that's in them based on your health and your well-being. And that's going to give your care team the ability to care for you, right? So if you just show up at a hospital at delivery time, well, no one can truly care for you well. They've not grown, built a relationship, or established any sort of care to make you any different than any Joe Schmo that's walked on the street, right? So there's something that's really important about establishing prenatal care with an OB provider or a midwifery provider, whoever you're choosing to have your care with. It is valuable to lock in that support and that care. And earlier the better. The earlier the better. And so we don't want to wait till we're 35 weeks and go, oh, I decided I should get some care. I can see this baby now. You know what I mean? And that happens sometimes. But yeah, so I think that's important. There's an undervaluing of it. And I think there's a needs to be kind of that family dynamic and that support around to create the additional emphasis on this is important. And even fathers have a huge role of like, I'm gonna take off. Let's get to this appointment. Let me know what's going on as well. So then we can work together and not just hold you accountable to maybe whatever is instructed, but like do it with you. There's a lot of men that are like, I'm sitting on the couch eating ho-hos and donuts and being like, well, the doctor said you can't have that because you're diabetes, but you're gonna eat it in front of her. It's not supportive. So those are just ways that I think we just need to have a better conversation and utilize the support to say, this is important. So grandma, maybe you babysit the kids so she doesn't have to have a babysitter. Maybe you find ways in your community to lighten the load so that this woman can attend what she needs for her well-being. I think Kwaizi was going to go.
Yeah, I was going to say I agree with everything you and Dr. Greenfield have shared thus far. I do also want to make sure that when we're talking about prenatal care, that we are considering why, like some of the reasons why Nicole has shared already, why some women are just not interested in prenatal care. Most of the times it's rooted in fear. We have a lot of social media now. We have a lot of TikTok videos, YouTube videos talking about how my birth experience was traumatizing. I survived it, like we talked about, but I do have like this comorbid type of experience. I do have something else that's caused me to be different afterwards. And a lot of women are like, I don't want that. So they don't go, right? A lot of times we're also not considering the fact of finances. Even if they have all the care, do they have enough money to get gas? Do they even have transportation in the first place to put gas inside of? A lot of times the answer is no, right? So again, they're not able to go, even if they're interested, into their prenatal appointments. And then we're not even considering like the stigmas and stereotypes when happening, like things that are happening at their prenatal appointments, reasons why people might not want to go. A lot of times I think the women are afraid to ask the questions that they want to ask because they don't think that they'll get the response that they deserve to have or a clear answer. You know, if a doctor is telling them, well, you have preeclampsia, and the woman is like, well, I feel like I've been healthy this whole time. Why do I have that now? And then the doctor's not willing to go into detail on what actually led to a diagnosis of preeclampsia. That leaves the women thinking, well, there's no point in me going if they're not going to give me the details so I can understand how I got to this point. I know Dr. Greenfield mentioned like a routine situation, like even in a routine situation, things can go sideways, right? But sometimes what is a routine, right? Like, why is there no options put out? Why are we only following a routine? So sometimes in the prenatal appointments, when women are asking to go away from the status quo, away from the conveyor belt type of process that the birth system seems to have sometimes when people are birthing in the hospitals, that leads to like tension in the room where doctors may not be willing to venture off for someone who wants to have an unmedicated vaginal birth versus a routine induction and all of those things, right? So I just think that in talking about the prenatal care, we have to talk about the fact that a lot of women haven't planned, unfortunately, for their birth. A lot of women are still in denial that they're pregnant, and they do wait until, oh, I can see it now. I should probably go and do something. Because unfortunately, especially with our recent abortion laws, I know that's a touchy subject, but some women did not plan for their pregnancy. They do not want their pregnancy. So sometimes they purposely neglect themselves in hopes that they won't sustain the pregnancy. And by the time they realize that the pregnancy has been sustained with whatever they were offering in the process, like, oh, I need to actually go and get some care. And so, like, those are bigger conversations I think need to be had about why we're not wanting to go to our prenatal appointments to begin with. That's my 2 cents.
Thank you all. And you hit on a few things. One, there were a lot of things you guys hit on, but I feel almost as if we need like an information card or something, and we need to put one on everybody's door, the type of thing that says some of these points that you all made. Because I just really, even someone mentioned about the fact that there are other things that can cause a woman not to get that prenatal care. For instance, having a ride to the doctor. As a city girl, it never dawned on me that, hey, if you're in a rural community, how close is a doctor, period, or one that you can trust, or no BGYN and all of that. So those are really good points. Also, when you mentioned the laws here in Arkansas, I did want to kind of bring this up. Right now there's a petition about getting abortion on the, not abortion, but a law around abortion, amending it. And I just wanted to make the point on this. It's not always just about abortion. So, there are women who may become pregnant, they intended to have the baby, and something went wrong. Based on the laws that we have now, a doctor, and Dr. Greenfield, you talk about this because I don't know the details, but I do understand that there may be, doctors may not be able to provide a procedure that is needed because they are in fear of breaking a law. So
a couple of things on that. I will mention, I did put in the chat a resource called Hear Her Campaign, and that is something that everyone can take away from here to help to help support moms, particularly in the postpartum period. On the issue of the controversial topic around abortion, I will make a few comments around that. I will speak to my personal practice. My goal is to help my moms and help my patients be as healthy as they can possibly be. And I don't really think that politics have a place in the exam room. That being said, politics are all over around maternal health in a lot of ways. And I will say that even in the OBGYN community, there are many folks who are actually split on that topic as well. So, one can never assume exactly even how physicians may feel around the topic of a host of things, abortion services, in fact, being one of those. With that said, yes, I think it is, and I can't speak to the legal issues in terms of where all the laws are right now, but certainly we've seen that be a factor in terms of women having choice in terms of how they manage and maintain or their pregnancies. Those are real things. I will sort of direct it back though, to the prenatal care visit, because over the course of my career, I've had patients who come in with a planned pregnancy. I've had a number of patients come in with unplanned pregnancies, those who wanted it, those who did not want to be pregnant, those who changed their minds along the way. And something that was mentioned by the previous speaker was that anxiety, that fear, that can almost lead to a paralysis of decision making. And this is back to the importance of that prenatal visit. There's prenatal care. And then what we would all say is what we really want is good, compassionate prenatal care. And good care, there's technically good care, right? Where you can do the right things. You can do the check boxes and all that kind of stuff. But then there's good care where the patient is heard and we're actually helping them get to their place. And I will say, and this is a little bit of a pushback from the medical side, just because a patient wants something, it may not necessarily be the best decision for them medically. And there are times when I may not necessarily endear myself to my patients because this is what I want. But I would say the first thing that we want, likely, that I can't say, is a healthy mama and a healthy baby. And my goal is to help us to get there. So all of these things sort of play into that. Back to your question on the issue of services and women's rights and that type of thing. Those are conversations, even this is why it's important, even when that prenatal care is established, because we are at that particular point, we're in that pregnancy. So we are, however we go, we got to go with that. But then after that, there's a point of like control of the reproductive life in the postpartum period. There have been things through conversations like this that have led to legislation that have provided for effective contraception. That type of conversation should be had in the prenatal care period. Long-acting reversible effective contraception can be placed, IUDs, Nexplanons, those types of things can be highly effective, can give protection from anywhere from up to 3 to 8 years. But I think it's really, really important as I look at your badge to say trust women to know that even those things, though, legislation can influence those things even going forward. So you should be aware that it is a process that does not stop. I don't know if I really answered exactly what your question was, but the point being that it's a very complicated thing. And, while we mentioned, and yes, that 15-minute prenatal visit, there's no way we can get it all in. But if we do effective prenatal care, we are going to have a number of visits. We're going to get to know each other very well, and then we can actually get all of those questions answered.
I just want to bend really quick on the topic of abortion and the laws and different things like that. Well, I don't know all of it. I am coming to the table saying, I think we need new terminology. So when we're talking about a woman who, has a loss in utero, that and needs a delivery, that is considered an abortion. That is not an actual abortion. If that makes, you get what I'm saying? Like, we're not aborting or ending the direction of this life. The life has ended in utero, and there needs to be some relief for that mother, for her to actually survive and thrive, and for her well-being. So on a personal note, this is just Nicole Fletcher having her moment. Um, I really do think that our terminology needs to shift, because when most people, they hear the term abortion, they're thinking a woman saying, I am pregnant, I don't want it, let me get rid of it. But there's so many other things that happen underneath that umbrella that is not that active choice of I made a bad decision, don't want to keep this baby, right? And so that's the first thing that I think of when I hear the term abortion. But the reality is, it's so much more complex than that. And so I think that's really important to denote. And I think if any sort of legislation can move, I would work on changing the terminology. That would
And, well,
be my
and I would say from a medical perspective, for us in the medical field, an abortion is the end of a pregnancy prior to 20 weeks without regard to how that pregnancy ended. In a lay terminology, we may think about it as a miscarriage, but we may call it a spontaneous abortion. Now, when the
Yes.
pieces of legislation actually begin to have an impact, and we have seen this, is that how someone is managed with a miscarriage. We frequently use a lot of medications, and people can avoid having surgery to manage that. And in issues that get to the management of medications, there has been episodes where that has interfered with good medical care of a patient who just simply by acts well beyond her control. She lost a pregnancy, and then care in some situations has been impacted. So these are a number of things that these can be unintended or consequences of processes that actually have nothing to do with what that patient's wishes were, but unfortunately, patients can become victims of these unfortunate unintended consequences. And like I said, this is back to the point of community conversations, trust, all of these things. And unfortunately, I think sometimes if we try to parse it out and just say, I can control this in a little box, you really, really, really can't. And I think this is where civic engagement, well, this is a whole other conversation, but the intersections between civic engagement and informed citizenry, a family support, good medical care, all of these things, ultimately getting to a patient to a place where when that patient comes in and they said, these are the things that I would like for my health care, we can have that informed conversation.
I think you make a good point, Dr. Greenfield. I think these conversations is what we really, really need to have. I did want to point out one thing that we wanted to make sure we got on this call, and that is the Kira Johnson Act. We wanted to talk about that act and what it is. Who best can speak on that for us today? Ms. Fletcher? Yes.
I was handing the mic to Kwaizi. We actually had a
Oh.
pre-conversation about this.
Okay.
Take it.
Take the conversation.
Oh, I'm taking it. Okay. So the Kira Johnson situation, circumstance is very disheartening. If no one is familiar with it, in 2016, there was a mother, Miss Kira Johnson, who went into a hospital that was considered a great hospital. I didn't know if I was on mute or not. I'm sorry. And for her area, this is her second pregnancy, and it was going to be a routine C-section. I'm not sure if it was because the laws were similar to Arkansas, where she had first C-section, so she had to have a second one. I'm not super familiar why she was going in for a routine C-section, but she was. Her husband has described it as a very typical morning. They got ready, they went in. She had the C-section, and everything was fine. They were in their postpartum room, recovering room, and he noticed that her catheter was starting to turn red. So there were some issues with bleeding, right? And he, got the attention of the staff and was basically like, hey, I'm noticing blood in her catheter. Can you check on her? The staff informed him, like, okay, yeah, sure, we will get a CT scan on her. Well, an hour goes by. They didn't do it yet. A couple more hours go by. He's constantly saying, hey, when is the CT scan going to happen? Can you come and check on her? He's noticing that she's starting to become pale in the face, that she's looking different, she's breathing different, and he's basically at one point pleading for them to come in. And the staff told him that his wife is not a priority right now. I'm not sure why the staff had decided that she wasn't a priority. There's various reasons that we already discussed on the call. It could be why they thought she was not a priority. Like, okay, the check box is marked, you had the baby, you're in the recovery room, we're going to let you sit there. By the time that they came to her, they still didn't even do the CT scan. They took her straight to the surgery room. And when they opened her up, she had several liters of blood in her abdomen and died instantly, right? So the Kira Johnson Act is basically a call to, the same thing that we're having on this conversation now, which how to pay attention to mothers of color, minority women, to listen to their voices when concern has been brought, to the table of the staff, being immediate, I won't even say reactive, but this is a reactive type of situation, but being proactive, which is like Dr. Greenfield has been sharing with the prenatal care, And even in the postpartum period, we have to be proactive and check in and check on things, and then be reactive quickly, right? And so her act is just a call out for all medical professionals, doulas, family, community, to learn to listen to a woman and her family when the woman is not able to speak for herself. I think that this act really brings into the conversation the role of the Black man with his mate, or any partner with their mate in that type of setting, because her husband was very vocal. A lot of men that I have been in contact with as a doula have felt at sometimes that their voices weren't important and that they were pushed to the side when it comes to caring for their woman prenatally even. And then also during the birth, they feel like they're pushed to the side and then brought back in. Whereas Kira Johnson's husband was right there. He said what he needed to say, and he's going on in her namesake, pushing for legislature, pushing for more information to be brought to the light. He got lots of calls from other families who had the similar situations, and he realized that this isn't one thing in isolation, but things that have been going on for a long time. And so that's his call to action. I'm going to pass it back to Nicole, because we did do something similar as we're involving like husbands and mates and men, and utilizing the village as part of the care, and making sure that women's voices are heard while they're giving birth. So,
yeah. Thanks, Crazy, if it's okay. I think it's really important when we, the reason why we are named Ujima Maternity Network. So Ujima is a Swahili word, and it means collective work and responsibility, making the problems of my brother and sister my own and solving them together. So when it comes to maternal health care, we really have to Ujima this thing, meaning working collectively and then taking responsibility. So when we think about the responsibility, not that we're quote unquote victim blaming, but there is a responsibility that you need to have, knowing about your healthcare, your well-being, your position, like regular, not even pregnancy prenatal care, just regular doctor's visits, right? Like knowing what's normal for you and knowing what's not normal, being able to truly advocate for yourself from a place of knowledge and not from, well, on Instagram and on TikTok, they said da 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 da, because that's the first way to get a little bit discredited, right? So you come to the doctor and you're like, well, on TikTok they was doing this, and I heard, you know what I mean? And cool, there's some good information there, but like, don't go to the provider with it. Like, call your doula and be like, can we filter this and can we find a good way to talk about this? But yeah, so like we need to Ujima that thing, and that includes the father. So just recently we brought in a gentleman, his name is called the Dad's Doula, and he's got an organization called FAM, and it's fathers assisting mothers. And his objective is to explain and educate. So he is a doula himself, but he doesn't attend the births as a doula. He educates the fathers about like the role of the doula, the role the doula can play, and the role that he plays as a father in support. Meaning, what's the game plan? What's the play? Is what he likes to, kind of talk about. And so he does childbirth as a football analogy, right? So he's like, gather your team. Who is your team? Like, get your players on board. And so who's your OB? Who's your doula? Who are these people that you're gathering as your team? And then what's the play? Let's create the playbook. What's she going to experience? How do you need to support her in that experience? So I think it's really important for fathers to be involved before something happens, before there is an issue. And particularly Black fathers, I think there's a creative way to help them navigate and negotiate the birth space in advocacy, because it's quick and easy depending upon the provider. Let's say you have like a white female provider who may feel threatened by this Black man who is passionate, and that's not her cultural expression or understanding. And then immediately, or even a white nurse, and that's not her expression or her understanding. So she feels threatened. And then people are called. And so there's an issue that is underlining that we have to also be aware of, and ways that we can collaborate, and we can, what I call Ujima this thing. And that includes the dads on the front end before something is an issue. Like if you're involved before there's an issue, that's when big impact positively changes and shifts towards her benefit ultimately. So yeah.
And I wanted to piggyback off of that. When it comes to being a doula, your doula is there to also not help with the mother's voice only, but also the father's voice. And so as a doula, I know that a lot of times there are people who seek out doulas and they think that that will replace the father or their partner, and that is not the role of a doula. A role of a doula is there to help you understand, as you say, bring that team together, those roles, letting the father know that his voice does matter, educating him so that he understands that when he is in that environment, he knows what to look for. He knows how to speak for the mother and the baby, and be a true advocate. Because a lot of times when we get into especially in a hospital birth, they kind of have that white coat syndrome where they're afraid to say anything. They kind of blindly follow what's being said to them, or even being trusting in a manner that is actually detrimental to them, from just, you're not a priority right now. Well, I have to be a priority, and knowing who to talk to, how to escalate in an effective way where it doesn't have to be combative, but it needs to be effective, and it needs to be where your voice is truly heard. And if the person I'm talking to, that voice, they're not hearing my voice, who do I talk to? How do I escalate past this person to make sure that the mother is getting the care and the baby's getting the care that they need? And so having fathers there to understand how to effectively communicate, and having a doula there to help the father understand how imperative his role is very important.
Very good points. And one of the things that I was just going to suggest on this call for people who had not thought about it is that I myself, just in general health, keep a notebook so that when I go to my heart doctor, I go to my general practitioner, I can kind of keep it, because it's very difficult to keep up with, oh, well, last month I felt this way or that way. But with my own daughter, when she was during her pregnancy, I made sure that she and her husband had notebooks where they were keeping up with how she felt and what was going on, what felt off, those kind of things. So that's one real effective thing to take with you when you go to the doctor, so that it provides some sense of, hey, I do know what's going on with me. So that can be helpful. I think I wanted to also kind of figure out, so this is wonderful. We really appreciate you all taking time to have this conversation. I personally would like to have this conversation more with more people in person, on Zoom, however we need to have it. But I will tell you, with the NAACP, and I think Wanquita, if I'm not out of line in saying this, we do want to continue this conversation in other ways. So one of the questions I wanted to ask is, what are the ways that an organization like the NAACP or any of our community organizations, how can we help in this area, help get some of these statistics down? And anybody can answer. Let's throw out ideas.
I think collaboration, teamwork makes the dream work. So, and not just collaborations from just having these meetings, but also funding. So having the funding to help with these programs, to connect those people, and also bringing people in the rooms where important conversations are happening. So, for example, with politics, we understand that though they might not need to be in the medical space, they are. So having, those connections and connecting those people to where we can have collaborative effort, we can have people, lobbyists, community leaders working together to help improve what we're in right now is a crisis. So making sure that they understand the depth of the issues, and having people in the space that they need to be to help resolve them.
That's good. One thing I would add is what Ujima is doing, and then maybe the NAACP could partner with. And so one of the things that we're doing is we're training doulas around the state, particularly aiming in the Southeast Arkansas part of the state, it would be beautiful if we could even just get an informational session together and like community members like understanding what these potential roles are. And that's not to say to negate the role of the OB or anyone else. Like, it is to say, how do we empower the community? So bringing together like the resources and the people that so they can have an educational spill, right? Then the second thing is they could potentially go on to train and be a community-based doula. So they live in this community, they're passionate about this community, and they're known by the community. They become a trusted member of the community in the maternal health space, and at least can kind of give some education and support. Or you need to get to the doctor, you need to get to the hospital. How do we pull these resources together? That type of deal. So that's one way. We do have funding to cover training for about 40 women in the state, and we are not we're not tapping, we're not even scratching the surface on the number of women that we have funding to train. So there's some value in that, and I think using the NAACP platform could help that. The other thing is scholarshiping. So scholarshiping women that need doula services and additional support, whether it's birth doula support, postpartum doula support, mental health support, therapies, chiropractic care, pelvic floor therapy, like all of that, creating a funding to say, we're going to scholarship or grant X dollars to go to this number of women to be served. So that's what we do with Ujima is we have a scholarship program. So let's say Laquita wants care and she lives in Dumas, Arkansas, and she's looking for a doula. So we're going to partner. She can apply for scholarship, and then we're going to find a doula that is closest to her geographically to provide doula support and care for her and help dot the I's and cross the T's, additionally support in her overall care and community. So these women can apply for scholarships that range anywhere from $500 to $1,000. Doula services generally are about, I'd say $800 to $1,500 is a ballpark here in the state of Arkansas. And what's covered during that is there's, usually 4 prenatal appointments. They're about an hour long. There's access to this doula, this support during the pregnancy, any hour. If she's got questions, they kind of help establish a birth plan. They're there with them, laboring with them at the hospital, until delivery and even into the postpartum, sometimes 12 weeks, sometimes up to 12 months afterwards, and having these partnerships. We also do a thing called a maternal care community outreach, where women can get services and support from doulas, from lactation counselors, and even from midwives to like have that additional, what I call dot your I's and cross your T's on your care, and maybe ask questions and have a longer period of time. Our next maternal care community outreach is happening in Monticello, Arkansas. So we're really excited about that. We'll be at the Pauline Baptist Church in Monticello. And so that's a free outreach. So women and families can come, moms, dads, grandmas can come and get support, get education, and get locked in. So that's an exciting thing that we're doing in a good way, from my opinion, that we can kind of work collaboratively. And the last thing I want to say is that there is not a sense of opposition, meaning like doulas aren't against OB providers and OBs should not be against doulas, right? There's not a sense of againstness, but a collaborative effort. So everybody understands their role. And when everybody does their role appropriately, the woman benefits the most, right? So this pregnant woman benefits the most when everybody is in their role and then working collaboratively to see her be successful. And that's successful and safe. And that's it. So survival, my last little note. Survival is a very low bar when it comes to maternal health care. So when we think about what are we trying to do? And we're like, we just want to help these women survive. That's a low bar. That shouldn't even be on the table. Like, it should be a no-brainer that you're going to survive this pregnancy and this birth, and your baby's going to survive. So what does it take for you to like go, that's the low bar. What's the high bar? Where we're going from here? What does it take to go from here? And that takes personal responsibility on everybody's side in order to change the trajectory. That's the Ujima effect.
Thank you, Ms. Fletcher. Dr. Anderson had her hand up.
Thank you, Donna. I'd like to say thank you to all the panelists. So Ms. Fletcher actually provided a segue when she mentioned informational sessions. So Ms. Fletcher, I have the pleasure to serve as the planning chair for the planning committee for the state convention of the Arkansas State Conference of the NAACP that's taking place in September. So I'd already mentioned to Ms. Nettles and Ms. Graves that we wanted something as it related to the Black maternal mental health at this particular topic. And so we can use that platform to have a discussion. So you guys will be getting an invite once I get with these ladies and figure out how that will go. It'll probably be a conversation that is like this, but where you guys can provide that info, like how to have the informational sessions, because we really need to. And Donna, also, you may have forgotten, NAACP was a partner with the Aftershock through Arkansas Advocates.
Yes.
I think that was back in January. And we started putting that information out. As a matter of fact, I think some of the sororities and fraternities was also a part of that.
Right.
Miss Nettles, the Roars, the Deltas, everybody. We were trying to just push it. But more importantly, education is a key. And I certainly appreciate you guys. I've heard things that I didn't hear before, but that Kira Johnson story just breaks my heart, to know that woman went 10 hours. Another thing, I'm also a talker, but I'm not taking up time. We have an NAACP in Monticello, so I need that date. And Donna and Miss Nettles, I'm sure we can share. And if you guys will let us know where you're going to be, and if it's something that the state president usually says, hey, let's run with this, and it can matriculate down wherever you guys are, we share it with those units. So if you'll let us know the date for Monticello, I'm sure Miss Nettles, Miss Grace, we can probably
Put it in the chat, Ms. Fletcher. Please put it in the chat and we'll share it with the
yes.
membership. Thank you.
So you guys will be getting invites once I get with these ladies. We'll figure out what date. It's either the 20th or the 21st. That's a Friday or Saturday. We're filling in the panel discussions now. So thank you.
Okay. Did anyone else have anything to say in terms of where, next steps? I think those were great ways that we can go. Looks like someone.
Yes, Ms. Fletcher is putting the information in the chat.
Yes, I want to share along the same lines with Nicole, really thinking about training as far as like collaborative efforts, right? However, whereas Nicole is like, we need more doulas trained, we need more information out, which I agree with wholeheartedly, and I love the idea of conferences and things of that sort. I think that there also should be efforts like just a general standard of training, right? At some point in time, our community has shifted what we consider to be a normal process when a woman becomes pregnant, how she's going to give birth, and then what the postpartum is going to look like. And a lot of times as doulas, we're combating that like pre-existing idea of you get pregnant, you go to the doctor or not, you get induced early, you get an epidural, or you get a C-section. And it's just pretty like that's the standard, right? A lot of information about just understanding birth in the body of a woman when she's pregnant is lost a lot in our community. So I think it's just general standard, like, do you know about birth? Or do you want to know about pregnancy and things of that sort should be kind of like on a more routine basis to educate our community as a whole on what the standard for birth is. I think there's a lot of work to be done on what the concept of the standard is. Is that like we need to know, okay, the woman has these stages of labor. This is what a contraction is. This is what the medicine does or doesn't. So that when doulas are trying to work with families and talk to a mom, and she goes back home and she tells her mom, but my doula said, I don't need an epidural. My doula said, I don't need an induction. And the mom is like, what did your doula know, right? That causes friction. That causes, frustration. Because, of course, a daughter is going to listen to her mother, even though she also trusts her doula. So, but when the mother herself, the grandmother, the uncle, the brother, everyone understands what a good standard is for a woman to go through while pregnant, that makes her risk, that reduces her risk in the birthing space, basically. When we just have a general community-based standard for pregnancy. Right now, it's very, like Nicole says, like down here, we're just trying to survive, but how do we survive and thrive? How do we survive and flourish? All of those different things. And I think in general, we just need a community training overall. Your everyday folks, come learn about birth, so that when your cousin's pregnant, you don't get her the wrong way.
Okay, I hope everyone understood. There was a little sound issue there, but it sounded like you were saying that we need an overall community standard and understanding of the birthing process. Correct? Okay. Dr. Greenfield, did you have anything along those lines or anything to add to any of that from the medical standpoint?
No, I say I appreciate all of the conversation, and I think all of this ultimately, to Ms. Fletcher's point, the standard is not survival. That's the minimum expectation. The standard we are trying to push for is to elevate patient care and to have an optimal birth experience. In the conversation, though, about the morbidity, mortality, are 2 points that I would like to just direct attention to. Number one, to keep in mind that when we talk about mortality, about a third of the deaths that can occur in a pregnancy-related death may occur after the 6-week period up into 1 year. So there's a period that shouldn't be lost. These things are not limited to the immediate birth time. That's number one. Two is if you take a look at, and I dropped it in the chat, the CDC's most recent report regarding maternal mortality nationally, conversations, activity, attention, action all have an impact. And you can see that we had a decline in national maternal mortality in 22 for the first time in several years after years of improvement. I just challenge everyone on this call to be aware that because we had a decline, the disparity gap persists. And so we have to be mindful that if we see a decline 1 year, that work is still to be done. And there will be work that needs to be done because we really need to close that disparity gap as we go forward. And then the last thing I would say in terms of actions and activity, I think reaching people where they are is incredibly important, reaching out to faith-based communities, reaching out into communities, particularly when we have maternity care deserts. Anything that we can do to help elevate those communities, make patients aware of the resource, and anything we can do to help bridge the gap between the patients and the resources that are available, be them insurance, be it providers, be it removing barriers, access barriers to care. The best care in the world, world-class care that's available that you can't get to, doesn't do anyone any good.
Thank you. Well, I really appreciate everyone on the call. I'm going to turn it back over to Ms. Nettles to kind of finish us up, but I really appreciate this conversation. As I said at the beginning, it's very near and dear to my heart for so many reasons, but thank you guys. And thank you for allowing me the opportunity to moderate our conversation today.
Thank you, Ms. Rayford Graves. You did an excellent job facilitating this pertinent discussion. We want to thank each of our expert panelists for taking out the time of your busy schedules to be with us today. Their contact information is in the chat for those of you who are attending with us. And any additional information, panelists, that you want to include in the chat, please do so at this time. And we will, the committee, the health committee, we will be sure to share it with our state conference membership. So please put all of the information in the chat. And once we edit this recording, we will send this to the NAACP state communications team so they can post it on our social media platforms. Again, thank you to our panelists. But before I go, I do want to recognize another health committee member. I'm not sure if she's with us, Ms. Cindy Palmer. She is the health chair in Sebastian County. Are you still with us? Again, we want to thank all of our panelists for being with us and sharing their passion and their expertise. And I also want to thank our moderator, Donna Rayford Graves. She did a phenomenal job. Everyone give her a hand. And on the behalf of our state president, Barry Jefferson, our state vice president, Ms. Wanda Neal, and the entire Arkansas State Conference of the NAACP, we want to thank each of you for joining us, especially our panelists. And any information that was shared in the chat, we will make it available to our membership and to the public. And we just want to say thank you and have a good evening.